Hello, everyone, and good afternoon, I think, in my time zone or wherever you're listening from. And thanks for the opportunity to talk to you guys today about the complexities and considerations of drug-drug interactions of oral antivirals for COVID-19. I am an infectious diseases trained pharmacist. And so as a pharmacist and then as someone in the ID space, this is a topic near and dear to my heart. And honestly, it's a topic that we used to deal with quite a lot in the early 90s with HIV therapies. And then this went away a little bit and now is back in full force with some of our COVID-19 antivirals. So we'll be walking through some implications for clinicians today. I apologize that I couldn't join you guys live, but it feels very fitting for a pandemic related talk to be recording this. And so thanks again to the organizers for the opportunity to record this for you today. These are my disclosures. Before we get into drug-drug interactions, I always like to level set and remind everyone the nuances of pharmacokinetics and a little bit of pharmacodynamics. I think as a pharmacist giving this talk, I'd be remiss if I didn't dive into PK just a little bit. So let's talk about PK in a nutshell to think about how drug interactions really interplay. So this seems very simple, but we have a patient, right? And this is our patient in the bottom left corner. Our patient is going to take any kind of medicine. In this case, they're taking an oral pill, okay, or an oral capsule. So when they do that, the drug has to get into the bloodstream, right? So we have to go through this absorption step that we call it. And then that level of the drug in the blood is going to have some kind of effect, okay? And those concentrations are going to slowly rise over time until it reaches a maximum concentration. So the dose you give can only be associated with so much drug, right? And that is our C max or a peak. Once we get to that, drugs don't stay around forever. Your bodies are trained to eliminate foreign substances. And so your body is going to work on metabolism and elimination to clear that drug from the body. When that happens, you finally get to a point where the concentration is so low that you need to take another dose if you want to maintain that effect. And so in infectious diseases and for most acute situations, we do this for a short period of time. For some conditions, patients may do this for the rest of their life, right? And that might look like taking something once a day or twice a day or 3 times a day or once a week, right? And this, when we have to take another dose, is called the dosing interval. Now, all drugs have what's called a therapeutic window, and this becomes really important when we talk about drug-drug interactions, right? Because if we give 2 drugs together and they don't impact each other at all, they're not messing with the therapeutic window, then we don't mind, right? Those drugs can safely be co-administered and they're not going to interact or cause varying concentrations. This therapeutic window is important because if we give too much of a drug, it's going to cause the patient harm or this unacceptable level of toxicity. But if we don't give enough of the drug, then we're not going to get our desired clinical effect and we're not going to have enough clinical activity. And so we want to dose so that we're in this window. Some drugs have a very wide therapeutic window, meaning they're very safe drugs. You know, interactions aren't as important because raising the concentration or lowering the concentration is okay. We have a really range of acceptability to do that. But some drugs have a very small therapeutic window. And so it's very easy to give too much or too little. Those are the drugs where dosing nuances are so important and drug-drug interactions become even more meaningful because we want to ensure efficacy of the agent and we want to prevent toxicity with our dosing regimens and the whole comprehensive medication picture of our patient. So with that frame of mind, the core principles of pharmacokinetics are absorption, distribution, metabolism, and elimination. So again, just to go through this at a very high level, absorption is how that drug molecule is going to get into the bloodstream. If you give something orally or enterally, then they have to go through the GI tract, they have to dissolve or break down or whatever else from the dosage form that's administered in order to get the active molecule of drug across the gut and diffusing into the bloodstream. And this process can take anywhere from a few minutes to hours, depending on the type of tablet. Sometimes it even releases over days if it has some kind of delayed release functionality. Of course, if we give something intravenously or IV, then we're injecting it straight into the bloodstream and we're bypassing that absorption step in this pharmacokinetic atmosphere. Then once the drug is in the bloodstream, it has to distribute to the site of action. So that's the distribution phase. And then, and when we look at this, you know, hydrophilic molecules are going to stay in the extracellular fluid. More lipophilic molecules are going to widely distribute into all kinds of body tissues, including fat. And so understanding distribution can also play into drug-drug interactions. And then, like I said, your body has to get rid of these drugs. They don't stay around forever. So there's a metabolism and an elimination component as well. With drug-drug interactions, at least for today, we're going to focus specifically on metabolism. So metabolism is where the body is going to modify the drug in order to make it more hydrophilic, since the vast majority of elimination is going to occur renally or through the urine. This is also called biotransformation in some settings, but in the pharmacokinetic space, we refer to it as simply metabolism. Metabolism can be influenced by a lot of different things, including organ function. As you get older, as patients tend to age, then metabolism functions tend to lessen, different perfusion status and hydration, and then, of course, our drug-drug interactions. The most active metabolic organ in humans is the liver. And within the liver, the most common enzymatic pathway of metabolism is the cytochrome P450 system. So this is in all humans, very common enzymes, and these are responsible for metabolizing drugs. In some of these enzymes, you can have differences from patient to patient. So there's variances between individuals, and this is an area of study we refer to as pharmacogenomics. And you may be familiar with this with medications like voriconazole and certain 2C enzymes and things like this. And this is, or if you are more in the cardiology space, perhaps, this is something with clopidogrel and other antiplatelets. And so understanding whether patients are rapid metabolizers or slow metabolizers can influence drug-drug interactions, and it can influence how we dose these medications. Medications can be substrates, meaning they sit on these enzymes. They can be inducers, meaning they cause that enzyme to become more frequent, more prevalent. They make more of the enzyme. Or they can inhibit, meaning they bind and block the ability of that enzyme to metabolize itself and other drugs. And some drugs can do all of those things with the same set of enzyme, which is pretty interesting. Inducers then, because they're creating more cytochrome enzymes, they're inducing the synthesis of these enzymatic pathways, they're going to ultimately decrease the concentrations of drugs in the body that are metabolized by these enzymes because they're creating more enzyme. So you're going to have more metabolism, therefore you're going to have less drug. On the flip, and what the focus of our conversation today is that inhibitors are going to increase drug concentrations of other drugs that are metabolized by CYP3 and 450 enzymes. This is because the inhibitors are basically taking this mechanism that's supposed to eliminate the drug and it's blocking it, it's inhibiting it. And this happens almost immediately. And so when that happens, those drugs are hanging around in your blood, they cannot be metabolized, and therefore the serum concentrations or the blood concentrations are going to increase. This slide says the same thing again, but gives you some examples. So the inducers are something I teach a mnemonic to all of my pharmacy trainees. Here at Pitt, we use a really brilliant Pitt head coach. I have a million derivatives of this mnemonic. If you want some more, I'll send them later. But this really speaks to the most common inducers, which are rifampin, barbiturates like phenobarbital, phenytoin, some of the older HIV medications, which honestly aren't really used anymore. So I just wanted it to make a mnemonic. So that's how I fit it in there. And then carbamazepine. But more importantly, what we were going to talk about today are the inhibitors. And I gave voriconazole as an example of something that has interpatient variability and a pharmacogenomics component, but it's also a strong cytochrome inhibitor. And then ritonavir. Ritonavir is a very important cytochrome inhibitor. And why do I care about ritonavir? Well, that brings us to our first COVID oral antiviral. And today I will only be going over 3 oral antivirals. I will not be talking about remdesivir, which is also FDA approved to treat COVID-19, but it is currently only available intravenously. And the focus of today's conversation is simply the orals. So Paxlovid, or nirmatrelvir ritonavir, was given emergency use authorization for use for COVID-19 in the United States in December of 2021. It's now since been FDA approved in May of 2023, and it is approved in other countries around the world for treatment of COVID-19. But interestingly, right after this drug first came out in January of 2022, so weeks after this drug received emergency use authorization, there was this really beautiful editorial or commentary in The Lancet talking about the caution of the wide-scale use of ritonavir. And the author said directly that ritonavir has a propensity for causing clinically significant drug-drug interactions with commonly prescribed and even over-the-counter medications. And this was really nice because, again, we hadn't used ritonavir a lot in clinical practice unless you were practicing in the 90s with some of the HIV antiretroviral therapy. When the development of integrase inhibitors came out in the HIV space, which largely replaced the protease inhibitor regimens, we were able to get rid of ritonavir because of the issues we had in clinical practice with all of these drug interactions. And so there's a good chunk of physicians, pharmacists, nurses that went to med school in the 2000s or later that really didn't see any patients with ritonavir, if ever, or maybe rarely. And so this becoming, common for a very common virus in outpatients was really, really important that we knew about this. The authors of this article said we would recommend that all prescribing clinicians become familiar with the potential interactions by use of dedicated reference guides, including the University of Liverpool, which I will talk about at the end of this talk, and liaising closely with their colleagues who have experience in HIV and other infections. And this is because that's the other unique thing about COVID, right? It is an infectious diseases, but the management of COVID-19 is not limited to infectious diseases specialists. All of us in any healthcare setting, inpatient, outpatient, in any kind of medical specialty, have seen a patient with COVID-19 at this point, and general providers and PCPs are the ones that are often prescribing these medicines. And so it's not necessarily referral to an ID specialist, and that's why everyone really needs to know about these drug interactions. So let's talk a little bit more about ritonavir. So again, it was launched in the mid-90s as a protease inhibitor for treatment of HIV. And ritonavir actually first came out as an antiviral itself. They said, can we block replication of HIV by using ritonavir like we do other protease inhibitors? And it found that you needed to have higher doses of ritonavir to really have that effect. And that was really hard for patients. There was a very high pill burden. It wasn't very well tolerated. And we just saw all these drug-drug interactions. But we realized that giving lower doses, so 100 milligrams a day or 100 milligrams twice a day or less, was better tolerated. And it was able to enhance the pharmacokinetic profile of other protease inhibitors. So that half-life, that Cmax, all of these things that we talked about at the beginning were able to be boosted, so to speak, by giving ritonavir with another protease inhibitor, which is exactly its role in Paxlovid, and I'll show you that on the next slide. So when you give ritonavir with another protease inhibitor, we see an increased Cmax and a prolonged half-life, like I just said. And we can use this then, like the benefit of this booster is that we can reduce the frequency with which we have to dose protease inhibitors, because otherwise we'd have to give them every 6 hours. And so when you give ritonavir, you can go to twice a day or maybe in rare cases, even daily dosing. And that means less pills for the patient and less variety and things like that. So it's very patient-centric to do this. However, you have this extensive drug-drug interaction profile. Most importantly, that it's a very potent inhibitor and substrate of CYP3A4. And that's where we're going to see most of our drug interactions. That is one of the most common metabolic cytochrome. But it doesn't just interact with 3A4. Ritonavir also inhibits and induces a ton of other enzymes. And so it really just is fraught with drug interactions, which we will go through. So on this slide here to orient you, so the y-axis is going to be the plasma concentrations of the drugs. The x-axis is time. And so you're giving a dose at time 0, and then you're seeing how much drug is available in the human over time. This was one of the first papers that came out in December 2021 in Science, looking at Paxlovid, which at the time was PF07321332. What a chemical name. So this was normotelavir, and it was looking at this exposures by itself, which is that black line that you see. And you can see when we give the drug by itself, that was giving it a 150 milligram dose. You can see by 6 hours, it's already below the EC90 or the in vitro level that we'd expect to be antiviral. So that's that dotted line that goes across. It already falls below that therapeutic index threshold by like 4 to 6 hours when you give the dose. But if you administer it with ritonavir, which is the reddish pink line, you can see that that booster maintains its therapeutic concentrations in that efficacy index for about 16 hours, which then I can give my drug twice a day, right? Instead of having to give it more frequently. And so the ritonavir booster really does help the protease inhibitor have its antiviral activity for longer in my patient. So that's why it's co-formulated. Ritonavir doesn't only work, though, on the day you dose it. And so a couple things about drug-drug interactions with inhibitors that are very important is that as soon as you administer an enzyme inhibitor, as soon as that gets absorbed and gets distributed throughout the blood, that interaction occurs almost immediately. So the ritonavir is going to go find that cytochrome, it's going to irreversibly bind it, and it's going to stay there, and it's going to stop the metabolism of other drugs. And so we see elevated concentrations of interacting drugs pretty much immediately after the drug is administered. And then it can actually last for quite some time. And I'll show you some data on that. And so even though for COVID-19, we're only giving a 5-day treatment course of nirmatrelvir ritonavir, this interaction still occurs and it's still clinically significant. And so just saying, oh, it's a short course for acute infection, I don't have to worry about those drug interactions, that's not correct. And if you do that, you will hurt your patients. And here's an example. So this was one of the first publications of real note after this drug became used in clinical practice, showing exactly how these drug interactions can lead to harm. And so tacrolimus is an immunosuppressant medication given to transplant patients who receive organ or cell transplantation to prevent rejection of the transplant tissue. So it decreases the immune system. It is also metabolized by CYP3A4. And so when you give ritonavir, that tacrolimus is going to stick around for longer. You're going to have elevated concentrations. So what happened is this patient had COVID-19. They got nirmatrelvir, ritonavir with their tacrolimus. And then a couple days later, they presented to the emergency department with fatigue, weakness, loss of appetite. And their tacrolimus level was 176.4. For perspective, in the transplant world, we usually have a goal of this depending on your organ you got and how far you are out from transplant. It can depend, but a goal of anywhere from like 3 to maybe 20 in really high risk patients is normal. And I'd say most patients live in like the 5 to 12 kind of range. So a 174 is astronomically high, and the patient had a ton of side effects from the drug because of that. That level was so high, and this drug is not dialyzable, that they actually used the cytochrome inducer of phenytoin to try to decrease that level faster and get the patient within therapeutic range. And so this is just a great example of how these drug interactions play out in real life. And importantly, ritonavir doesn't stop working the day you stop taking the dose, because ritonavir is an irreversible enzyme inhibitor. And so it essentially eliminates that enzyme completely until your body's able to make more enzyme. So the half-life of ritonavir is about 3 to 5 hours. And so some people might think, oh, 3 to 5 hours-ish after my last dose, I have half the concentration, and that, that inhibition effect will go away and I'm good to go. This was a nice study that was done in JAC in 2020, and they showed that that's actually not the case. And they looked at lopinavir ritonavir, which was another early HIV medication that was at the beginning of the pandemic repurposed and evaluated for treatment of SARS-CoV-2. It didn't pan out to be an active therapy for SARS-CoV-2, but it gave us good data about ritonavir and about some of these drug-drug interactions. And so the authors basically did this study because they said, the duration of this effect is not really well understood, and we want to evaluate this. So what they did is they gave lopinavir ritonavir 400, 100. So basically ritonavir 100 milligrams twice a day for 7 days in order to achieve steady state. And then they looked at drug concentrations of interacting medications. In this case, they looked at midazolam for 21 consecutive days thereafter. They stratified this by age because as patients advance in age, they do have different metabolic functions and metabolism. And what they found was that within 24 hours after stopping ritonavir, they did see a profound decrease in this inhibition. So about 60% in younger patients, about 46% in elderly patients. But that means half your patients still have a pretty dramatic interaction effect. And they found that over time, that effect lessened. So within 72 hours, they found that most of this had gone away. But some patients took up to the full 21 days to have full eradication of this drug-drug interaction, meaning there was still some interplay out to 21 days after ritonavir had stopped. And so again, after you stop ritonavir, you need to resynthesize CYP3A4, and that ability to do that is going to depend a lot on the patient. And so they concluded that even though the inhibitory effect is reduced by 80% after 48 hours in most adults between the ages of 20 to 50, and then it takes about 72 hours as you get in more advanced age, there are still issues. And so they advise to not restart or resume normal doses of other COVID treatments for up to 2 to 3 days after you stop the interaction. And so with Paxlovid, this would look like not restarting your normal doses or your normal drugs until day 7 of disease if you're getting a 5-day treatment course. There are tons of drug-drug interaction databases to look at what you should do for these drug interactions. So things like tacrolimus. There are tertiary databases that exist for all medications, but we should caution with those because they use HIV literature mostly. And there is a difference when you're taking something for 5 days versus taking something for your whole life, right? And the way we're going to manage that interaction is going to be different because there are some things that we can temporarily stop for a 5-day course, or there's other things, if you're going to need them for life, I can't just stop it for life. We have to find a different medication. So there is different management there. The Liverpool database, which I mentioned, is COVID-19druginteractions.org. The screenshot you see on the screen is the Liverpool database. So it can show you if you're giving something for 5 days, for 10 days or longer, are there different considerations and what should you do? So that's a really nice tool. And then the NIH in the United States has a reference as well. This is our UPMC guidance. And let me tell you, this took us a long time to come to harmony on. I had a group of about 15 pharmacists who were working on this diligently, and there was a lot of disagreements and a lot of places where there just simply weren't good data to guide what should we do. And there's a lot of patient by patient consideration on what to do. But what we tried to do is group these into 3 categories. So things where it was absolutely contraindicated because immediate harm was going to come to the patient. Things where we could maybe temporarily withhold the concomitant med because it's only a 5-day course. And so could we get away with a temporary hold? Or things where, we can probably continue them together, but maybe we need to dose adjust, or maybe we just need to monitor. So that's how we tried to group it for our clinicians. Using tacrolimus or our transplant meds as an example, here is our recommendations. So we wanted to call out specifically, like, you need to talk to a pharmacist before you prescribe this medicine. You need to let their transplant coordinator know. There needs to be good communication whenever you're starting drug interactions, and therapeutic drug monitoring is strongly recommended. We recommend to hold tacrolimus while the patient is getting Paxlovid, and then at day 6 or day 7, check a level. And then if the concentration is appropriate, to restart it at day 7, or to continue to hold if it's still elevated. And so it's very patient by patient. But this is challenging in the outpatient space where patients may not have ready access to labs, or we might not get labs back in a timely manner. And so this is very hard to navigate. And I think the most important thing is communication. When you're starting ritonavir in a patient, you have to do a holistic check of their med list every time. Don't guess, don't try to I'm a pharmacist, I'm going to look it up every single time. I'm going to plug the patient's entire med list into a drug interaction screener, and I'm going to get a critical assessment of what I need to do, because it is complicated and it's not times we should be guessing, we should be confirming. Very briefly to end here, I want to talk about the other couple of drugs that are out there. So ensitrelvir is available in Japan. It is under phase 3 trials in the United States. Interestingly, they're looking at this medication for long COVID-2, which is the Scorpio SR trial, and it was given FDA fast track designation in April of 2023. This is a protease inhibitor only without ritonavir. So that is interesting. There is no ritonavir here. However, this protease inhibitor in and of itself is also a CYP3A4 inhibitor at both of the dosing strategies it's being studied at. And this photo on the right here is a curve of giving midazolam alone, which is 3A4 metabolized. That's the clear circles, versus giving midazolam with ensitrelvir, which is the dark circles. And you can see how much the concentration of midazolam is elevated in the presence of the protease inhibitor. So even though there's not ritonavir, there is still a drug interaction here. And this timetable just shows you that just like with ritonavir, it can last many, many days past your last dose of ensitrelvir. So this is looking out to day 5, day 9, or even day 14. And you can see that there are still elevated concentrations even after the drug is stopped. And the last available oral antiviral is molnupiravir. Molnupiravir received emergency use authorization on December 2021 as well. So I think the day after normotelvir ritonavir received it. It has a unique mechanism of action, and because of that, there really aren't a lot of drug interactions. The only drug-drug interaction listed in tertiary databases is clodarabine. because of this intracellular unique mechanism of phosphorylation, that there might be some therapeutic interaction there, but nothing with cytochrome or metabolism. So as pharmacists and nurses, I think pharmacists are uniquely positioned to navigate complex drug interactions. Since it's not usually a simple like take or don't take a medicine, it's actually quite complex and looking at dosing and how to modify, et cetera. I strongly recommend collaboration between every prescriber and a pharmacist to determine the best path forward for a patient when prescribing anything with ritonavir in it. And nurses are so vital to this too, because nurses are the last line of defense in medication administration. So in an inpatient setting or a community care setting, the nurse is going to be the one to give the patient the med. And so nurses can also be our teammates by double checking before administering anything with ritonavir or really any protease inhibitor to a patient, because drug interactions do exist. And with that, here's my contact, and thank you so much.